Very good evening to one and all, and warm welcome. We have gathered here for an insightful academic session, an academic feast that is to follow. As per recent ICMR INDIAB study, 30 crore Indians have hypertension, which is 3 times more than diabetes. Patients are often diagnosed late and they present with established hypertension-mediated organ damage. ESC Congress 2024 was held recently, and new guidelines on hypertension management have been published. To discuss key takeaways and recommendations and understand how it can translate to Indian clinical practice, we have with us the eminent speaker, Dr. Abraham Oman, sir. I have the honor of introducing sir. Sir is senior consultant cardiologist at Apollo Hospitals, Chennai, currently president of Heart Failure Association of India, has numerous publications in national and international reputed journals, and has immensely contributed in clinical research as being a principal investigator in many landmark trials. We are honored to have you, sir, and we welcome you. Sir, over to you.
Thank you very much. I will share my slides. Okay. Okay, thank you very much for this opportunity. And another important thing is hypertension is a very important topic, and thank the organizers for doing this. And there have been multiple guidelines, and ESC 2024, one of the concentration was on hypertension management. So I would try to discuss the guidelines. What does the 2024 ESC guidelines say in a broad way? So as said before, hypertension is a global calamity. It affects about 1/4 of the global population, and number is supposed to be more than 1.6 billion by 2025. That is around the corner. And it is the single largest contributor to death. So when we ask my fellows or other doctors, what is the single largest contributor to death? People say generally diabetes comes, generally lipid comes, generally cancer comes, but hypertension doesn't come that often. But hypertension is a absolute faraway leader for as a contributor to death. You can see here, and it contributes to ischemic heart disease, stroke, heart failure, atrial fibrillation, renal failure. And we all know that 60 to 70% of the people die of these non-communicable diseases. And the problem is, again, non-diagnosis, non-adherence. And the cost of hypertension is about 500 billion worldwide. The older thing was 50% of the people did not know they were hypertensive. Among the people who knew they were hypertensive, only 50% took medicines. And in the people who took medicines, only 50% were controlled. Another way of looking at it is that 30% are untreated, 35% are treated and controlled, 35% are treated but uncontrolled. These are the people who have been diagnosed as hypertension. And this is my favorite slide, and this is one of the things which you should always remember. Because when we ask this question, pound for pound, which is the most dangerous ailment or malady, is it high HbA1c or high sugars? Is it high LDL? 1 millimole is roughly 39 mg/%, or is it 4 millimeter reduction in systolic blood pressure? If you see the number of cardiovascular events prevented per 200 patients in 5 years, it is about 12.5 for lowering systolic blood pressure by 4 millimeters versus 3 out of 200 in 5 years for reducing HbA1c by around 0.9 or 1, or LDL by about 40 mg/%. If you reduce, you get about 8 less events. So this is the importance of hypertension, and this is the relevance of this talk and relevance of we spending time this evening. And this Indian data, like very commonly quoted, 33% of urban Indians, that is 1 out of 3, and 1 out of 4 rural Indians are hypertensives, and 21% Indian men and 22% Indian women suffer from hypertension. And the 25% rural and 42% urban Indians are aware of their hypertensive status. So there is very common problem, hypertension, but awareness of that is still quite limited. Now, coming to guidelines, there have been multiple guidelines. And first, before coming to the ESC, let us quickly go through what are the previous guidelines. And this is 2023, this before that. So what is normal? So let us look at it holistically, because if you start crunching numbers, you'll never remember it. So hypertension definition, by the earlier definition more than 130/80, then they relaxed it a little bit more than 140/90, but normal was always less than 120/80 here, and less than 120/80 was considered optimal here. And elderly people were given slight leeway in the recent guidelines, and beta blockers were included as first-line therapy for hypertension, re-included, I should say. But older guidelines, beta blockers are served for specific conditions, including ischemic heart disease or heart failure. Now, the ESC 2024 again has gone back to the older beta blocker, but that is relevant for a lot of Indians. So what changed? They changed the name. They changed the name from guidelines on the management of arterial hypertension to guidelines on the management of elevated blood pressure and hypertension. So that is interesting. So there's a demarcation between elevated blood pressure and hypertension. And to me, this is another important slide. If you see here, how do you measure? And this is very, very important. If you go back with one key point, I would not even look at, say, the numbers or the medications. I will emphasize this. So this office blood pressure, this is home blood pressure. And I will concentrate on home blood pressure, because office blood pressure, it is a little challenging, but it should be done. But home blood pressure is much more easier. When I asked my patient, I asked about nearly 500 patients who are very educated, very wealthy, and very proud of their BP monitoring skills. And it was nearly 100% was not doing it in the correct way, nearly 100%. Almost everybody. I can't remember a single person who knew. And when I was told this is how you check the blood pressure, they said, nobody told us that. So this is important. Use a validated BP device. Many times they'll be having devices with not much validated, you can say that, or very old machines. In a quiet room after 5 minutes of rest with arm and back supported. And previously it was 3 readings. Now they made it simple. Obtain 2 readings, 1 to 2 minutes apart, and take the average of it. And twice a day, morning and evening, for at least 3, ideally 7 days. So this is something which you should tell the patient, because most of the times, they will take only one measurement, they'll come rushing and then take one measurement, and they will be panicky, and the whole concept will change. So this is my single most important or very important message. In the office, how do you measure? And this is a challenge, but you can still do it. So what they say is measure after 5 minutes, sitting comfortably in a quiet environment, and correct cuff size and the BP cuff, the level of the heart. They said take 3 times and average the last 2 reading. Then always check for the orthostatic hypotension. record the heart rate, record in both arms at the first visit at least, and further measurement or further evaluation if the difference is more than 10 millimeters. So this is a challenge in most of the Indian offices, but try to do it if there's a place. One way to do it is like the nurse measures the blood pressure and allow only one patient after another. That is important because if you send many people together, it becomes a bazaar. So somehow this is not moving. Okay, sorry. So now the criteria. So they divided it into non-elevated blood pressure, this is ESC 2024, elevated blood pressure and hypertension. Remember, the name given the guideline was guidelines on elevated blood pressure and hypertension. So what is non-elevated? There is a consensus here: office, home, and ambulatory BP monitor less than 120/70. So it changed from 120/80 to less than 120/70. So somebody having a blood pressure of 114/66 is not low BP. It is non-elevated blood pressure. But again, let us, elevated blood pressure is 120 to 139 systolic or 70 to 89. And so that is office blood pressure. Let us concentrate on hypertension because too many data you will forget. So 140/90 is more than 140/90 is considered as, in the office, is considered as hypertension. 130/85 by home BP monitoring or ambulatory BP monitoring is considered as hypertension. So remember three numbers: normal less than 120/70, office BP more than 140/90, or home or ambulatory BP more than 135/85 is hypertension. In between is elevated BP. What are the key highlights? So what they looked at was, they looked for a target of 120 to 129 for adults with BP lowering medications. So somebody on BP lowering medications, the ideal target is between 120 to 129, and also concentrate on patient tolerance and specific conditions. Tolerance was highlighted, and more lenient BP for people with symptomatic orthostatic hypotension, very elderly, frail people, and limited life expectancy. This is understandable. Out-of-office BP measurements are emphasized. There should be a personalized approach. If 120 to 129 is not achieved, then try to go for the next lowest possible blood pressure. And there should be shared decision making. Focus on cardiovascular disease outcomes, and that is very important. And so the stress is not on the numbers, but on CVD benefits. So what's new in recommendations? Class 1B is validated and calibrated this device. So ask this patient to bring the BP machine to you, and please teach them the correct measurement technique. Because if it's not done, and it's a class 1 indication, a lot of confusions occur. Then look for white coat hypertension and masked hypertension, because sometimes people can have high BP in the hospital and masked hypertension. They can have normal BP in the hospital or office and high BP at home. So both should be looked in. So for that, home BP measurement or ambulatory BP measurement is very ideal. Then how do you measure for orthostatic hypotension? The BP fall is more than 20/10 and should measure at 1 and 3 minutes of standing, at 1 minute and 3 minutes, or at 3 minutes. So you should check the blood pressure, make the patient should be sitting or lying down for 5 minutes, make them stand up, and at 1 minute and 3 minutes, please check the blood pressure. And more than 20/10 drop is considered orthostatic hypotension. Another important thing is go with a risk-based approach, not blindly by numbers. And look at the risk for cardiovascular events, look at CKD, diabetes and hypertension-mediated organ damage. Europe, they recommend score, but I would recommend the QRIS 3, the simplest, which includes Indian ancestry or South Asian ancestry as one of the risk factors. I recommend QRIS 3 as the risk scoring. Always take a note of the pregnancy, and pregnancy, because if it's remote pregnancy, ask for gestation diabetes, gestation hypertension, preterm delivery, preeclampsia, stillbirth, and recurrent miscarriages. South Asians have been brought forth as a high-risk ethnicity. And look at 10-year risk. And so these are the things to be looked into. And here you can see high sensitivity cardiac troponin or BNP has made an appearance here. And it is so please, it doesn't cost much, but it indicates the cardiac damage, and they require very focused and broad-based approach. Not only hypertension, but the lipids, the sugars, weight, everything should be controlled. And how often do you check? So less than 40 years, every 3 years, and more than 40 years, every year. Among people listening to me, how many of us had their BP checked in the correct way, not in a rush way? Somebody comes in the correct way in the last year, in 2024, it's a point to ponder. And if the risk thresholds are not reached, then repeat BP measurement is an important thing. And always screen for hypertension. That there should be systematic screening, self-screening, and non-physician screening. The patients with increased cardiovascular risk, look at the target, and then use ambulatory BP monitor, home BP monitor. And I recommend teach everybody home BP monitoring. And always evaluate for adherence. The commonest cause of BP not getting controlled is non-adherence. So that is something which you should really look into. And again, if you've got CKD, again, check serum creatinine, GFR, and urine albumin creatinine ratio at least annually. At least annually is the word. It is not once in a year. At least once a year, if preferably more. And the calcium scoring in higher risk patients is a class 2B. It is not a very high risk, high point, but class 2B. And resistant hypertension should be considered for referral. And secondary hypertension should be thought of and looked, and also look for primary aldosteronism, especially people with low potassium. So what they have recommended about the sugar, restrict free sugar consumption to a max of 10% of energy intake. That is quite important. And this recommendation should start at young age. If they start taking a lot of sugar sweetened beverages like Coke or Pepsi or equivalent, then in young age, that will have a repercussion later in multiple ways. And like the sodium intake, especially in patients with CKD, should be controlled. And the increase of potassium intake by only 0.5 to 1 gram per day. This is important, but many people have seen substituting like with high potassium diet too much. That also is not good. So what they recommended is 75% sodium chloride and 25% potassium chloride, or through diets rich in fruits and vegetables. Then this is again very important. And this is a matter of lot of discussions. Timing of drugs. So it's a class 1B recommendation to take medication to the most convenient time of the day for the patient. If the best time is night, take at night. Best time is morning, take at morning. But there should be a habitual pattern, because this has to be an habit. And what I personally found is evening is sometimes where time people don't forget. But if they're comfortable in the morning, yes, please do that. And look for the cardiovascular risk. The more than 10% in 10 years is not good, and they should be aggressively treated. Young adults, if anybody less than 40, screen for secondary hypertension. And if especially people with short history, but like hypertension-mediated organ damage, then again be aware and be more aggressive. Pregnancy, it should be a team approach along with obstetrician, and also the diet and exercise is important. As I said before, home BP monitoring and ambulatory BP monitoring to exclude white coat and masked hypertension. So then older and frail patient, but then in Europe, it's a major problem because a lot of people are living longer. When we see a lot of people. So the elderly and severely frail people look at the tolerance level and have a holistic approach, because too aggressive treatment, postal hypotension, falls will be a criminal offense. And in more than 85 years, frailty, then what they say is long-acting dihydropyridine calcium channel blockers or RAS inhibitors, followed by a low-dose diuretic if tolerated, and preferred not a beta blocker unless compelling indications, or alpha blocker. So this is something which you should remember. Very older people, unless if they have angina or heart failure, avoid beta blockers and alpha blockers. So the frailty and the life expectancy is an important point. And if the BP falls, then try deprescribing drugs also. That is also important, because many of these drugs. And another important thing which you have to understand is the sedatives and prostate-specific alpha blockers can reduce the blood pressure dramatically. So if somebody has postal hypertension, and you should think about all these possibilities. Then, as I already mentioned, how to check the blood pressure is important. Non-pharmacological approaches is first line, and so also avoid drugs which can worsen orthostatic hypotension. Another interesting guideline was CKD and GFR more than 20, SGLT inhibitors get class 1A indication. This is something which is not followed in our country. Many people still believe that, falsely believe, I should say, that SGLT inhibitors are nephrotoxic, or they produce diuretic, excessive diuresis. Answer is no to both of them, and it's one of the most cardio and renal protective drug known to humankind. And if you are missing the patient, this is a hypertension guideline. Then another thing which is patients with pre-diabetes or obesity, and the BP is more than 140/90, it is very simple, this 140/90 business. Anybody with higher risk, definitely start treatment, not even waiting. There are multiple comorbidities, start treating. If they are pre-diabetes or obesity, then BP lowering drug should start upfront. And patient with aortic valve stenosis or regurgitation with hypertension, RAS blockade. Mitral valve regurgitation needing BP lowering, RAS blockade. But they are class 2A indication. And it should be patient-centered, and there should be motivated. Good patient communication is important. Self-measurement, when properly performed, is very important, and multidisciplinary approaches. And there are multiple mechanisms, and then renal mechanisms, neural mechanisms, socioeconomic, psychosocial. It's very important. Spend some time with the patient. Environmental factors, noise pollution, air pollution, and epigenetics, and all those things are important. So who are the higher risk patients? Patients with established cardiovascular disease, CKD, GFR less than 60, or albuminuria more than 30. The other cardiac or vascular damage as by evidence by troponin, BNP, left ventricular hypertrophy, peripheral vascular disease, diabetes. Familial hypercholesterolemia is again a risk factor. So we have to initiate, implement, and persist. Each point is important and should keep on doing all these three, because unless you chase them, the BP treatment becomes very poor. Hypertension mediated organ damage. Our score 2, again, there are two problems. One is for the people for more than 40 years, but I prefer CURIS 3 because it includes Indians or South Asians as a group. And how do you look for hypertension mediated organ damage? Calculate eGFR, look for albuminuria, look for LVH, and echo, specifically look for diastolic dysfunction. Tell your echo cardiologist, return the echo if there is no E by E prime, no E prime value, no LA volume, no LIV index. And again, this is very, very important. And this doesn't cost anything. Unlike if you have to do a troponin, it costs something. But when you do an echo, adding this costs nothing. And many times this is missed. And any E prime less than 7, it indicates diastolic dysfunction. No question about that. So please do that. In cardiomyopathy, HMOD troponin I and NT-proBNP has made an appearance and is very important because subclinical damage can be assessed. Carotid Doppler, pulse wave brachial ankle pulse wave velocity, cardiac CT score, all are important. Non-pharmacological approaches, which includes non-pharmacological approaches are many, so we know most of them, and which includes aerobic exercise at least 150 minutes, brisk walking, jogging, cycling, swimming, daily physical activity, take stairs, avoid sedentary lifestyle, resistance training, low to moderate intensity, including plank, wall sit, hand grip. These are 3 sets of 1 to 2 minute contractions enough. So, but don't overdo it. That's also important. Then you can try squat, push-ups, and a rough rule of the thumb is that nearly 75% of the exercise can be dynamic or it can be aerobic, and rest 25% can be isometric or resistance training, which includes, as I said, plank, wall sit, squats, push-ups, sit-ups, etc. So potassium intake I mentioned, physical activity I mentioned, optimize weight management, reduce table salt intake, stop alcohol, no smoking. Pharmacological methods, it's very simple. They made it very simple. Start with low dose double combination, followed by triple combination. So what is, in specific situation, start monotherapy when patients with severe frailty, limited life expectancy, severe orthostatic hypotension, and older patients. So how do we do it? The initial combination is the ACE/ARBs, calcium blockers or diuretics. And I may add thiazide-like diuretics. If not, low-dose triple combination therapy is still not controlled, then we have to have a reassessment. So beta blockers. Beta blockers are to be added at any step. That's again interesting. At any step, if there are compelling indications, angina, post-MIs, heart failure, and heart rate control. This is important because we had done a study in Indians, and in Tamil Nadu, people with hypertension, we did ambulatory Holter as well as ambulatory BP monitoring. And in Tamil Nadu, the average heart rate is 82. So we Indians have high sympathetic drive. So that may make it a class 1 indication. So beta blockers are not thrown out in this guideline, but I think it has got specific relevance in Indians in view of the heart rate. Then this is what, if there's resistant hypertension, 4 drugs, one of them diuretics and not controlled, definitely a hypertension clinic or specific hypertension specialist. Spironolactone can be added, eplerenone can be added. The combinations, as I mentioned before, the ACE inhibitors or ARBs, dihydropyridine calcium blockers, thiazide or thiazide-like diuretics, and combination of these. Beta blockers, as I said, in the specific indication. This is a very interesting chart, and I think you should keep it in your clinic because people, and there is, I request all the stakeholders to even distribute it to the patient because it's very easy to remember. And I do this for lipids, and I do the giveaways or takeaways I give to the patients are one on lipid similar, green, amber, and red. So any LDL for people is with CVD or at high risk of CVD, anything less than 60 is green, 60 to 100 is amber or orange, and more than 100 is red. Very simple. Similarly, if you see here, from anything from 140 onwards, it is red. 120 to 139 may be orange, and 120 to 80, there's a systolic blood pressure. The systolic blood pressure, remember, is green. Somebody has got a blood pressure of 104 is still in green. That is something which we should remember. Patient-centered care. So what are the key messages? The hypertension is a worldwide malady. New category, elevated BP 120 to 139 and 70 to 89 diastolic. Focus on cardiovascular disease outcomes. So there are the new terminologies like the systolic blood pressure load and time in target. Now we know this for diabetes. We know this for lipids. Now we will talk at time in target or the lipid variability, glycemic variability. So this is important. So this is where the home BP measurement comes in. If you regularly check the BP from home at least 3 times a week, and it takes hardly 5 minutes or extra or 7 minutes. So that can be train them, make it a habit. Then we will know the pattern. And if patients with the time in therapeutic range is high and the cumulative blood pressure load is lower, the event rates are lesser, no doubt about it. And another interesting thing about elderly people is that check both supine as well as sitting position, and also obviously standing position. And the intensive BP control reduces events. We all know that. And treat the risk, not the number. And the higher the risk, aggressive treatment, better benefit. There is no doubt about that. That reduces cardiovascular event as well as death. And this is common sense again. Higher burden of elevated BP, higher burden of cardiovascular disease. And again, the big question people ask is this from Sprint. It's an older data, but we know it more and more. So intensive BP control, hypotension is about 2.4, syncope is 2.3, bradycardia is 1.9. They're all very small numbers. So don't be afraid to aggressively treat blood pressure, but keep a watch. So look at the benefit and harms, and harm from treatment is postural hypotension, falls, and very aggressive treatment in people with a very limited lifespan. This is a slide I had made about, I think, 3 years back. And it was interesting to say that this was my slide. Aim for 0 cardiovascular events. Don't just achieve numbers. Aim beyond numbers. Move from blood pressure reduction to organ protection. In 2024 ESC guidelines, if you have to summarize, it is the exact 3 points. Aim for reduce cardiovascular events. Don't just achieve numbers, aim beyond numbers. Move from blood pressure reduction to organ protection. And again, one of my favorite statements, and this is a quote from Dr. Venkatas Ram, who's the doyen of hypertension in our country and the world. And he called hypertension a hemodynamic malignancy. So when a patient is told that he has got malignancy, they panic, they get worried, they are willing to do anything and everything. So hypertension should be considered as a hemodynamic malignancy. And if they have the target organ damage, then that should be considered as secondaries. So any patient with hypertension with target organ damage should be considered having hemodynamic malignancy with secondaries. No target organ damage, that should be considered equal to a hemodynamic malignancy. I conclude by saying what you can do today can improve all your tomorrows. If you control your BP and your patient's BP, you can improve the patient's tomorrows. With that, I conclude and stop sharing the slides.
A wonderful session, sir. Very crisp, sweet, direct takeaways, even for the Indian patient and the Indian diaspora. So we have a couple of engaging audience questions, if we can just take them as a discussion, if it's fine with you, sir.
Go ahead.
So Dr. Indrajit asks the first question. Very interesting, especially from the Indian perspective. So he asks on mercury BP monitorers, the sphygmomanometer, the conventional sphygmomanometers versus Android devices. So we are aware of the Minamata Convention out, but your take on the same, sir, for the Indian practitioner.
Yeah, there was a belief, and there is still a belief, that mercury manometers are more accurate. I should say that they're not exactly true, maybe because mercury manometers also has to be calibrated, and most of the mercury manometers have never been calibrated. That's point number one. If anybody is having a mercury manometer, please think back when it was calibrated. That's point number one. Point number two, it is removed because mercury is a health hazard. So with both points, I would not recommend, but the other, that should be like well accepted ones, but not by, and much more easier. So for patients, general patients, much more difficult. Home BP monitoring, the mercury manometer is very, very tough. So I would not recommend, and now it's very difficult to find a mercury manometer. But the belief that it is more accurate is not correct. Calibrated machines are correct. And bottom line is calibration. And health safety also.
Sure, sir. So we have, so you showed in one of your slides, this already very well put, but, and you also mentioned about the scenario of Indian patients, especially with the Tamil Nadu patients, the study having high sympathetic activity and a baseline pulse rate. So Dr. Tanmay asks in similar light, so beta blockers for uncomplicated essential hypertension in Indian clinical care settings. Your take on the same?
Yeah, it is, see, Indians with their huge burden has made the thing very easy. To find a Indian hypertensive more than 40 or like, okay, more than 30 with no other risk factors is extremely rare. If you they will have obesity, they will have pre-diabetes, they will have so many. So Indians have a multitude of risk factors. That is point number one. Because about Indian diabetics are around 101 million, pre-diabetics are another 200 million, obese are 315 million, hypertension, so huge numbers. So to find a person with no other risk factors are very chances low. That's point number one. And if they have resting tachycardia or resting higher heart rate more than I would not find, because now it has come in guidelines. They made it a little more easier, because there was always a question. It went out and then came back and then again. But Indian scenario, if you think the patient has got sympathetic, that is very common with the IT professionals and also young doctors. So we should not forget that. So a lot of stressed out this thing and heart rate increase. So I would not be hesitant to use beta blockers. But we would look at holistically. Somebody's like BP's, no other risk factors, BP very well controlled, heart rate also okay, with a combination of RAS plus a calcium blocker or diuretic, I would go for that. But other situations, definitely, I will consider beta blockers.
Duly noted, sir. So, an interesting question by one of our audience, Dr. Ashish. So I'll put it in context. Probably, Dr. Ashish, probably I'm putting it into context based on the question you asked. So, sir, he asks it more from the perspective of the Indian scenario where patients often come to the hospital directly with signs of hypertension-mediated organ damage without a past history of hypertension. So, CKD as a cause for hypertension or as the effect of hypertension, especially when the patient first manifests with CKD. So the chicken or which came first, the chicken or the egg hypothesis. In clinical practice, how should we try to find out, sir, if a CKD patient comes?
So
CKD as a
first thing
cause of
is,
hypertension.
say hypertension causes CKD and accelerates CKD. CKD like can lead on to high blood pressure due to so many mechanisms. So, but I think for the vast majority of patients, it would be hypertension would be the initial thing, undiagnosed, untreated, and hypertension CKD will perpetuate, accelerate, or accentuate. But somebody has, membranous glomerulonephritis or something else, and then kidney is bad, BP can, that also can go. But that number, if you see the huge number of patients, that will be lesser. But for our perspective, it is very simple. Whether I will put it another way, if the cat is white or black, it should catch the mice. Similarly, whether the CKD or no CKD, if there is blood pressure, control it.
Wonderful, sir. So Dr. Brijesh asks, so whom should I choose, or how should I choose patients who I should send for a coronary artery calcium scoring, and what cutoff value should I use to intervene?
Okay, so as I showed before, it's a class 2B indication. So the simpler things first, but then if you think that patient is, my approach would be very simple. One, there is something called QRIS 3 score. It's freely available. It takes about, actually counted, it takes about 30 to 45 seconds to calculate. And if they are at higher risk of the 5-year risk is more than 10 or 20 comes at very high risk, then you should assess. And if they are asymptomatic, the calcium score is very good. Calcium score is good in 2 ways. One is assessment of risk, and from the Western population, starting statins. So if anything 0 to 100 is 0 is perfect, but 0 to 100 is okay. Anything more than 400 is roughly equivalent. The prognosis is as bad as a triple ulcer disease. So remember, 0 is perfect, more than 100 is bad, more than 400 is bad, very bad or ugly. Now there are certain caveats. The caveats are, this doesn't hold good for smokers, diabetics, and patients with strong family history of CAD. And another caveat I would like to add, that we are in the process of collecting the data. We had actually personally collected. We have a program called ASCAPS, Apollo Subclinical Atherosclerosis Project, where we do all the things, including CT coronary. And we have found that the people with zero calcium score can have significant atherosclerosis. Maybe like significant, we put it as plaque more than 30%. So maybe in the future, South Asians also may come in that category. But if they have, the whole point is if they have multiple risk factors, they come under high risk category. So the fallacies of calcium score, repeating, smoking, family history, diabetes. So majority of our patients get out of that. Then get out of that means a huge number of diabetics. Maybe South Asian ancestry, that is not in the guidelines. So that is where calcium score stands now.
Thank you so much, sir. So Dr. Dheeraj asks, hypertension with atrial fibrillation, your clinical pearls for management in these patients.
The first thing is hypertension can cause atrial fibrillation. That is something which you should remember, because they can have lesser dysfunction. And so I will concentrate on hypertension part. So if the high heart rate, beta blockers, because we already said high heart rate, they did not specify hypertension or atrial fibrillation, but atrial fibrillation with high heart rate, beta blockers would be my choice, especially if they got hypertension. So hypertension, atrial fibrillation, beta blockers come high in the list. Then I may avoid drugs which may increase the heart rate, theoretically, like some of the calcium channel blockers. Then other things neutral. I try to control the blood pressure very strongly, because hypertension can, as I said for CKD, can beget atrial fibrillation and perpetuate atrial fibrillation, because it produces diastolic dysfunction. And the slide I showed, look for diastolic dysfunction, because look for E prime. E prime less than 7 is bad, bad, bad. So, and E by E prime more than 14, it costs nothing. So remember 7 and 14. And so E prime less than 7, E by E prime more than 14, they are bad. So, and these are the patients who may get into atrial fibrillation more. If we talk about atrial fibrillation per se, like I work in an institution where everything is available. So early rhythm control with ablation, there are many ablations, so many type of ablations. So has been found to reduce mortality and event rates, but that's not applicable for majority of the Indians. So rhythm control may not be possible for majority, but rate control may be possible. And rate control with hypertension, beta blockers, the things including amiodarons and other class 1 drugs are possible.
Thank you, sir. So Dr. Sujit asks a question. In clinical practice for the first line management, who is best to benefit with an ARB plus CCB combination versus an ARB plus diuretic combination? How to choose? Is there any evidence to choose one patient population for one subset of combinations over the other? So
there are studies for and against everything. So that is, so I would like my personal, because the guidelines are very clear, all the guidelines, you can choose like any of these three, but prefer, because Indians are at very high cardiovascular risk. So what has been shown to reduce cardiovascular risk? Definitely, number one, control of blood pressure. Without that, nothing happens. If you give wonderful drugs and BP is not controlled, then so what I tell the patient is, whatever way, controlling the blood pressure is the key. Point number one. What are the drugs with maximum cardiovascular protection? It's ARBs and ACE inhibitors. Then maybe a chlorothalidone or indapamide in some trials. Calcium blockers, yes, in some trials like value trial. So I would I would leave that choice to the practitioner. But the commonest combination, if you're diuretic and if you have to pass urine more, it may be of a concern. So don't give that combination the night hour. And people with prostatic symptoms, sometimes it may be challenging. So individualize the patient. That is how I look at it.
Thank you, sir. It's an interesting question. So Dr. Siddharth asks, in the Indian scenario where getting patients down to the ISH guidelines, the ISH guideline normal or target of 130/80 itself is difficult, how relevant is the new normal for diagnosis not for diagnosis, but the new normal of 120/70 blood pressure in the Indian context? How relevant is it, sir?
I would put it in what I tell my patients is my personal take is start treatment if it's more than 140/90, aim for less than 130/80. Simple. But the relevance, what I find is that, see, that green area, that picture. So many people may not, if somebody reaches, it's very good, you should aim for that. If you don't aim aim for the stars, you won't reach the moon. That's how it's said. So you should try it, because just because there's a false belief among patients and caregivers that, oh, BP will not remain. And many people are very proud. My BP is always 150, 160. That is something which you should remove from the doctor's mind and patient's mind. And patients say, I'm perfectly fine at 150, but if it becomes 140, I feel bad. So that needs counseling. Another way of countering that is do an ambulatory BP monitor. And you say, obviously there will be a time when the BP is 130, BP is 120. And you ask them, did you feel bad at this time? They say, I was perfectly normal. So for you, 120 is also okay. This is important because many people staunchly believe that, okay, still that 40-year-old formula, 100 plus age. And this produce harm. And once the harm is done, you cannot go back. And that is what, as caregivers, we should all realize. And we already said primum non nocere, first do no harm. By not controlling the BP adequately, the word is adequately, it should not be okay. Everybody less than 120 is very challenging. I agree to that. But if some try for that, anything less than 130/80, I am happy. Personally, that is my mantra. 140/90 and start at more than 140/90, aim for less than 130/80, and if less than 120/70 is fine. And show that. I think you should give that chart to everybody. Two things is important: how to check the BP and that green, amber, and red zones. And to me, they are the most important messages.
Duly noted, sir. Wow. So the last two questions for the day. So we have a question from Dr. Vyas, who asks, ARNI for hypertension management without heart failure, is it a foreseeable future or a far-fetched claim? Your take on the same, sir.
It is neither a foreseeable future or far-fetched claim. It is real and present now, because it reduces blood pressure more than about 5 to 7 millimeters more than ACE inhibitors. Actually, ACE inhibitors are maybe as good or even better BP reducing than ARBs. So if BP is not well controlled, you should try everything. So the point is, there are many things you can give, because this is not highlighted, but then we didn't have time. See, never rest until the BP is controlled. If the ARNIs reduce BP, resistant hypertension, there are a lot of papers, there are some guidances, posting statements that come. So don't be afraid of giving ARNI if the BP is not controlled. The moxonidine, centrally acting drugs, don't be afraid to give. Then even like I personally have given a set of people minoxidil. It has been found beneficial. And there are papers on that. So to me, the true resistant hypertension with all these things becomes less. There is a terminology called resistant control hypertension. So that most of my patients come under that difficult category. The previous resistant hypertension now come under resistant control hypertension with all these things. And never forget alcohol. Many of the people drink without their spouses knowing, and that is applicable for males and females nowadays. And so alcohol can increase the blood pressure dramatically. Then again, stress and all those things. So we have to look at it holistically. And like, I personally believe that if the BP is not getting controlled, primarily it is what do you call, where I would not call a fault, but it's like something more to be done by the practitioner as well as the patient. So both people are guilty of doing something less. Then, okay, we have renal denervation and things like that.
So, as you just mentioned, that was the last question for the day. The role of renal denervation in clinical practice for hypertension.
Okay.
Words of wisdom.
Yeah, basically 10 years back, we were all very gung-ho. Then came the Simplicity trial. Then there was a sham arm. So everyone patient believed that they were getting the denervation, and it was a negative trial. Now it has come back. There are many newer ways. We know why we failed, but it is reserved for a very small category. And the cost is tremendous. So it will be for the truly resistant hypertensive people with no renal artery stenosis. It can be tried, but the numbers are very, 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 very limited, even though it's FDA approved. Having said that, future is injectables, and once in 6 months, silbesiran is once in 6 months. You take a shot. So it's a near future. It's not, maybe in 5 years it would be there, and another 7-8 years it'd be out of intellectual property rights. So in 2034, Dr. Parthasarathi and Dr. Charmi and all will be talking about something else. And the future of is small differing RNAs. If the cholesterol is high at the age of 30, you take one shot of inclisiran or equivalent. The lipoprotein is elevated, you take one shot of the drug. If the BP is high, you take once in 6 months silbesiran or the equivalent of that. If you're obese, take the GLP-1 and its combinations. And this can prevent a lot. It's like we are going towards prevention of many, rather than treating the disease, preventing the disease. And of course, lifestyle modification. There is nothing without lifestyle modification. And that is the most difficult and challenging part.
Wonderful, sir. Wonderful. So we've reached the end of our audience Q&A, and we've had a very wonderful, a very engaging session. The discussion also on the guidelines was unlike a very didactic session. It was always with takeaways for the Indian population. So that was one thing which was hugely appreciated. We have a lot of people in the audience who have actually given their appreciation points and duly noted the same. It was an honor to have you with us, sir, and to engage our audience, to educate the audience on the same. Our dear audience, we thank you too, actually, for taking your valuable time out on a Friday evening. We also understand we have a lot of logins from Maharashtra and nearby areas too, where actually the current festive season is on. So thanks for actually joining in to empower yourself and your clinical practice to ultimately, which we are very sure will improve your patient care outcomes. Last but not the least, we also thank our technology partners, DocMode, for aiding in the very smooth streaming of this wonderful session. Thank you so much, sir.
Thank you very much.